Welcome back to the Physio Foundations podcast, where we talk about the knowledge and skills that provide the foundation of expert clinical practice. So today we're talking adherence in rehabilitation, and we've got an expert in adherence in rehabilitation in Bec Phillips here. And I've got some questions related to my clinical experience when I've been working as a physio, and also related to Bec's PhD that she's just handed in and is being examined at the moment, which is very exciting. So rather than do a lengthy introduction to all Bec's vast experience, we're going to ask her to tell us all about it. So Bec Phillips, welcome to Physio Foundations.
Thank you very much, Luke.
It's really good to have you on at last. So I've known you for a few years. I work alongside you in our group, the Monash Musculoskeletal Research Unit. I work with one of your PhD supervisors, Peter Maliaris. So we know each other from our work together, but I don't really know enough about your research, the details of what you've done. I've got lots of questions that I always ask you about, and I figured we could do it as a podcast conversation. So tell us about you, your professional background and interests, and then we'll lead into what you did for your PhD and the details. So tell us all about you.
Okay. Thank you. I'll try and keep it brief. After 3 decades of working as a physio, so primarily as a musculoskeletal private practice clinician, probably after about a decade or so of that, I was a little bit disillusioned and maybe just questioning my effectiveness in producing sustainable results for my patients. And so that led me to clinical Pilates, which really revolutionized the way that I approached my assessments and tailoring treatment programs, exercise particularly for my patients. Most of what I did was equipment based, very much movement, direction, preferenced exercise prescription, and that I found worked very, very well in achieving results for my clients. So that kind of was the next decade of physiotherapy for me. And then I was looking for something new again. I feel like this is something that seems to happen around about every decade or so, just reflecting and thinking about the future. So then I started thinking about academia, returning to some study, and PhD. So that was a little while in connecting the dots. I was a bit naive, I guess, in that you don't just go, oh, I think I'll do a PhD and then sign up and enroll. It's a little more complicated than that. And having not had any joining points between my graduation as an undergraduate physio without honours and then stepping into PhD was not as easy as I'd expected. But fortuitously, one day I did have a conversation with Terry Haynes, who I didn't have any idea who he was, about his seniority, about his amazing research record, and his position at Monash as the school head of the head of school. Yeah, head of school. Thank you. Anyway, so Terry had suggested, as I was leaving his office, to no, that's probably not going to work. But as I was leaving, he suggested that I get in touch with Peter Maliaris, and I did that. And Peter was great. He invited me to be a research assistant on some of his projects, and I was introduced to the world of research. And then COVID hit the world, and that turned out to be an opportunity for me to work on one of his research big trials, actually. So an NHMRC funded, really big trial looking at mid-portion Achilles tendinopathy at high volume injections. There were 192 participants. So I was able to roll out that that trial along with another colleague of ours with the Monash Musculoskeletal Research Unit. So that led into my PhD study. That I had access now to participants in Peter's trial, and Peter had agreed to be my PhD supervisor as part of this process. And off we went. So it was kind of learning on the job, very, very steep learning curve from clinical practice. Rolling out the trial was fine. It was very much like clinical practice, but all the stuff that goes on alongside that and how I would approach my research project, that was all very steep learning curve, which, has 4 years later, having handed my PhD in December, has given me some time now to reflect on how much I actually have learned. It's quite a big career transition. But yeah, having access to participants, having access to people that I was able to form my study around, my area of interest being adherence after a long clinical career and observing what we do in clinical practice. It's busy, we treat patients and then, often prescribe exercise as part of our treatment. It's part of the clinical practice guidelines for many different musculoskeletal conditions in particular. And then having patients come back and often they were not doing what I had prescribed or doing a variant of, or certainly not doing the frequency that I had thought we'd agreed on. So that exploring that area of adherence was particularly of interest, I think, too, when I started to look into the research and hear about patients being considered to have failed conservative therapy or failed conservative management. And that phrase really bugged me. That phrase was something that I was like, hang on a minute. How can you say someone's failed conservative management and then send them off to more expensive, more invasive procedures when you don't really know what they were given? Did they do what they were given? We don't know if that's the clinical practice guidelines. That's the best evidence that we have for treating this condition, and yet they're being considered to have failed when we don't even know if they've engaged with it or not. Was something that really motivated me to study adherence a bit more.
It's like saying you failed to, in a game of sport that you didn't really turn up to, or you didn't understand the rules of, for example.
You lost the game, but you actually didn't show up, or you drove in the car park and you might have met the other team, but you didn't actually play. Exactly. It's like meeting the other team, not playing, and then losing the game.
Well, we explore adherence in depth. I'm glad that you gave us a bit of your background of your clinical career and then how you ended up going into research, because we've got a number of pathway to research episodes on the podcast for listeners to go back and look at if they're in your position of being a clinician and saying, how would I even start? How would I even do that? Professor Krishna Sadnik comes to mind. Terry Haynes, you mentioned, has talked about that topic on the podcast. So they're good ones to go back and listen to those perspectives. And then, so currently, so it was August, you said last year, you started at Charles Sturt in Orange in New South Wales. So your lecturer position there. So you're doing clinical practice, teaching, research, the singing, dancing, acting triple threat.
I'm doing a little clinical practice, not a lot, but primarily my full-time role now is research and teaching. So it's 40% research or close to. It's in the process of the EBAs being in transition period, but close enough to, and then 60% teaching.
Can we go back? I do want to go forwards to adherence, but we've got time here. I do want to go back to your diverse and very interesting career inside and outside physiotherapy without me hinting too much. Tell me a bit of the other stuff you've done overseas with different populations of people.
Yeah, so alongside raising a family and a private practice clinical career, I also was the founding director of a foundation that one of the primary things that we did, or reasons for our existence, was a micro enterprise in Kenya. So outside of Nairobi, it's probably an hour or two outside of Nairobi. It's not many kilometres, but it took a long time by road. So in a children's home, so Mama Obed Children's Home, housed about 20 kids who had found themselves either orphaned or had extended family who were unable to care for them. So 20 children at that time living in a tin shed, essentially, supported by community, supported by some members of a church that we had been introduced to. And so we partnered with the organisation who was supporting these kids and created a chicken farm that funded, so that all of the profits, 100% of the profits, went into funding the education costs for these 20 children who were about the same age as my kids. So that happened in about the introduction was probably 2013. And so those kids now had their entire education funded. Most of them now are either at university or doing TAFE courses, and we got to go back in 2023 and meet some of the kids, and so that was the micro enterprise, and that micro enterprise actually introduced me to the effectiveness of addressing upstream determinants of health and broadened my worldview from the downstream interactions that I'd primarily had as a clinician, that we see the patient at the interface of their needs, but stepping back and considering economic factors and political factors, socioeconomic factors, cultural factors that play into somebody's health. So over the last, I'm going to just use the word decade again, so it's working for me so far. So probably it is just over a decade that I've been working with somebody that I met at that time. He's a Maasai man in Kenya, and we've partnered together to create a micro loans business for rural Maasai people. A lot of the people we support with micro loans are women. And in fact, we have helped through funding the economic microloans, helped a group of Maasai women who were widowed. Widow's a whole complicated area in a polygamous society. I won't go into that just here and now, but these women were in very vulnerable positions with no resources at all, little education, no resources, and children. And so we have funded these women to be in agriculture, and now they own cattle, which is very, very significant in Maasai culture. They're the first Maasai women ever to own cattle.
Wow.
And cattle are very prestigious in Maasai culture. So that's been one of our really big achievements, but we are helping now through this microloans business to fund many people in the rural parts of Kenya, Maasai people particularly, and starting to do a bit of research in that space as well. So I do, in my spare time, I do supervise some DPT students, which I've been doing with the University of Melbourne through their healthcare and context unit. So I've done some supervision of these students doing some research alongside my business partner, Rogers Mitten-Keeney there. And so now we're starting to measure the social impact, and that will help us in getting the word out and increasing our capital raising for being able to continue to provide these loans to people, addressing the upstream determinants of health, to be able to help them educate their kids, have a nutritious diet, and reduce the vulnerability. One of the key things that these women, and particularly their children, particularly girls, are vulnerable to sexual exploitation due to the effects of poverty, which creates a whole lot of issues with pregnancy, and that's the link with health. So doing that in my spare time.
In your spare time, yeah. Really interesting. How many trips to Kenya do you think you've done for that project?
Well, I probably at times I've been every year. Then I missed a couple of years during COVID. It's probably working out at every other year now. So 10, 12 maybe.
Amazing. And your original physio training and all that clinical experience, What skills and knowledge did you use? Was it complete? Do we consider that completely separate from your private practice physio career? Or are they intertwined?
They're definitely intertwined. I can see how people might consider them to be completely separate, but actually I find them to be really linked. I think one thing that physiotherapists do very, very well is problem solve. So every patient that comes into your room, you have a limited amount of time, and you have to connect with the patient, engage with them, and learn about them, what's contributing to their condition, what condition they might have, how you might address that, how you might communicate and educate them around managing that, and provide a treatment in a quite confined space of time, which you then, once you release that patient, then you bring the next one in and start again. So definitely the problem-solving skills and being able to identify what could we do here that might be able to contribute to managing this condition better or this situation better. So problem solving, I think the way that physios connect with people is also another skill that has works consistently in building these partnerships and relationships, but also with the people on the ground who are recipients of these loans and understanding their needs. So at the very beginning of this process, I spent I'm going to call it extended periods, because when you've got, my kids were probably in their adolescent years, but I did stay the first time for about 3 weeks on site at the children's home. And I went to school with them. I went to parent-teacher interviews. I would take them on my run in the morning. So it'd be me and 15, 20 kids coming for a run. I talked to the people who were caring for them. I was in the kitchen, which is like a sort of outdoor, no, I wouldn't even call it a shed actually, but it's, so I learned, I did the dishes with them, I did the chores with them, and I just learned about what their life was like and spoke to their carers and what are the challenges, what are the barriers, what are the enablers. So my research is largely qualitative, and I didn't realize it at the time, but essentially I guess I was developing those skills at the time, living on site, observing, having conversations, connecting with people, and learning, being curious about the cultural factors. At that time, I was also doing some work with SOS Health Foundation, which existed for about 10 years or so, started by Jason Smith, who also started Back in Motion, which he has sold now. But at that time, he was engaging with a couple of different communities, First Nations communities. And so I found that the curiosity of learning about Maasai culture and learning about First Nations, the different cultures of the communities that I was with, similar questions, similar learnings. And I'm very, very grateful to the people who were so generous with their time and so generous with me to let me make mistakes and say inappropriate or maybe, not inappropriate, but maybe insensitive things that they were able to teach me a lot about. I was able to learn a lot by being curious, and their patience and kindness to teach me. So those skills around curiosity, skills around problem solving, skills around connecting, communication, and more broadly, I think physio is not just about hands-on treatment. There's a lot of physios, a lot of the skills we learn help prepare us for health promotion, for education in a broader sense, for policy development, and addressing some of those more upstream determinants, because we have a really good handle on how the system works. We have to work in both systems, private and public. We have minimal Medicare funding, and we need to understand how both the business world works, and also how the public health system works. And so that, I think, places us really well to be contributors to policy and health promotion.
There are many highly ambitious, outward-facing students with outward worldview who are really interested in doing more than just their primary skills of physiotherapy. That was our a question I ask all guests. I want to know, what do you think are the most important foundational knowledge and skills for a physio? So we've gone there first, which in this episode, which is really good. Problem solving skills, curiosity, obviously communication, and you mentioned earlier the upstream factors, so the geopolitical and economic and cultural factors. So then the opposite is true as well. You're going to take all of that knowledge back to the Australian context, and that obviously helped you with your PhD. How do you think your PhD would have gone as a new grad, doing a topic as complex as you did, versus Bec with 30 years of world experience and clinical practice experience?
I think it would have been very different. I think I brought a lot of my life experience, physiotherapy experience included in that. I've got a lot of my life experience to developing the question. And being so heavily qualitative, I also brought those skills to in communication to each interaction, to each semi-structured interview, and reflective practice as well. So there's a lot of reflection that goes on in qualitative research in order to develop your interview question set. And the work that I have done personally and the life experiences, I think, enabled me to have that self-awareness and also the awareness of humans, just human behavior. And behavior change is essentially it's very close to adherence. So behavior change is largely my I guess it's my thesis theoretical underpinning. And without the knowledge and experience that I had, I think I would have found that very challenging to do at the depth required to make the PhD a really valuable contribution of knowledge to the world.
And that's specific to your project and what you did. There are PhD projects that people have just graduated will go straight into academia and do a PhD, and that's appropriate for them. But that gives us some really good context for what you did in your PhD. So let's talk adherence. What do we mean by adherence? What's a definition? And then we can talk about what you did in your research and then application to practice for clinicians.
Yeah, so there that what you've just said there is true, that defining it is probably the first thing that you need to do, because there is not one accepted definition of adherence in the literature. So the definition that I went with is according to Frost from his work in 2017, was the extent to which individuals undertake a prescribed rehabilitation behaviour accurately and at the agreed frequency, intensity, and duration. So I summarise that as saying perfect adherence, essentially. So that did the patient do exactly what I asked them to do? And when I rated adherence, patients got a 1 if they did exactly what I asked them to do. Did they do the sets, reps, frequency, intensity? Did they progress when they needed to progress the exercises? Did they regress if they needed to regress? Did they follow the exercise instruction, but also the physical activity advice? Did they modify their load if they needed to modify their load, or progress their load, regress their load? So they got a 1 if they followed all of those components of the rehab delivery, and they got 0 if they did not follow all of the components. So it was not a near enough is good enough approach, where, the way we define adherence as physios is really varied, including in the literature, and we're kind of working on tightening that up. But it is really varied. It's not very often measured and not very often reported. There's a brand new measurement scale that's just been developed by Daniel Bailey in the literature. But it's not very often measured, not very often reported. And so what people mean by adherence is quite variable. Some physios would consider that just did the patient show up. So in some studies, if patients attended a session, that's adherence, or they measure attendance, frequency of attendance as adherence. In others, they will kind of, in clinical practice, I think sometimes people overload the prescription of rehab in order to try and, they know people are not going to do exactly what they are prescribing. So rather than adjust their prescription, they might overload that prescription to account for the fact that people are not going to do exactly what they're being told. So, but I trusted people to do what I was asking them to do. And I wanted to know, how we started with, if you're giving people an exercise prescription, I didn't want it to be said that exercise prescription had failed if they didn't do it. So
that failed conservative management terminology again. Yeah. So not just exercise, so physical activity, changing in loading, activity modifications, other advice.
Yeah.
And we're thinking of, so I was thinking of self-report versus objective measures of adherence. So that probably I'll probably ask a better question. What did you look at in your PhD in terms of measuring adherence?
Yeah, so my PhD did not look at measurement. It didn't look at did they adhere or did they not adhere as far as my analysis and my study. So okay. I did track what people told me when we followed everybody for 52 weeks. I had 59 people that I had interviewed across this time at 6 different time points. So when they came back at each of these 6 different time points, I asked them what they were doing. Essentially what they did in the last week, because we were not having weekly follow-up. So I asked them what they did in the last week. I noted that on my own sort of tracking sheet. And then I looked for patterns of high adherence, partial adherence, and low adherence. And I wasn't hard to find the high. That they were, if people did it, they were on track. Partial were people who maybe something got in the way and they got off track for a while, or it might have been that they started well and then petered out, or it took a while to get their head around what was being required, and so they took a while to ramp up. And low was essentially people who were the program didn't they did adhere somewhat. So some physios would have considered it full adherence, but they modified what I asked them to do to make it sort of work for them in their current lifestyle. So I wasn't, but I then used that information to analyze the interviews, because I was most interested in the why. I was most interested in what optimizes adherence and what are the influences of adherence on patients that we see. So, and these were people who had entered a clinical trial, so they were already somewhat motivated. They knew they were signing up for a year, but also they all had moderate to severe mid-portion Achilles tendinopathy to be included in the trial. And they had all seen a health professional before, all of them. And some of them were doing, most of them had been given an exercise prescription, which is part of the clinical practice guidelines. So clinical practice guidelines would say people with mid-portion Achilles tendinopathy need exercise, education, and also activity modification. But not one of the participants I interviewed, not one of the 59, was adhering to the clinical practice guidelines, despite having moderate to severe pain and having seen a health professional, and most of them had been prescribed exercise. Not one of them was adhering to the clinical practice guidelines, which I wish I could say it surprised me. It didn't surprise me. But importantly, I didn't blame the patient. My hunch was that was more about the delivery of the rehab that they'd been given, which was what I was interested in drilling down to. And I guess the fact that then most of these people by the end of the trial were still adhering to the program that we had provided them, the rehab delivery that we'd provided. There was around 70% of patients were adhering. That to me says it wasn't about them.
So the focus was on what healthcare professionals can do to optimize adherence rather than what the participants or patients didn't do.
Correct. It was about what influences adherence. Tell me about what's influencing you. It would simplify it to say that it was about barriers and enablers. It was about a lot more than that, but essentially it was about me understanding the influences on their adherence behavior.
That makes sense. What did you find? Give us a summary.
I found that it was so what optimized adherence, what influenced adherence was largely related to the way that the rehab was delivered. So there are kind of 3 different profiles of people, and like I said, a part of my sampling was looking at people with high adherence, partial adherence, and low adherence. And essentially those with the high adherence really needed quite specific detail. So They were the ones that came highly motivated, quite structured in their approach to just life in general as a generalization. But they were the ones saying, well, what exactly do I need to do? I've tried this, I've tried that, I've looked online, I've listened to this podcast, my coach says this, my friend says that, but it's not working. So I'm here for your expertise. I'm part of this trial. What do I need to do? Give me the detail. What exactly, how much, how often, for how long, when do I progress? And what's that threshold? So what if I've got this pain? What if I've got that pain? What's the threshold for when I progress or when I regress? And how much pain is acceptable? How much is not acceptable? Where's that line? And they wanted the specifics. Where's the line? When do I do this? When do I do that? So I found that interesting. I kind of thought that everybody would need that from my clinical experience. And probably that was a big learning for me. That's probably the key learning, is actually not everybody is the same. That rehab delivery does need to be tailored to the individual. But in tailoring, there are some profiles that we can identify as physios. So that was the profile of the specificity, that the patient that you don't need to work too hard to. Most physios would, listening to this, and probably even students who've been on clinical placement, could pick that. That's the one that the patients ask for it. The second category, or the second profile, was essentially around coaching. These were people who really, the therapeutic relationship was really important. They really needed to have that interaction around, how do I apply this? I can hear what you're saying. I need to understand why. If I'm going to modify my life and I'm going to integrate this into my life, tell me why. And so it was about that. They come back. This is, and also, I guess, creating a safe environment. So patients would come back and say, all right, this is what I've done. This is what I haven't done. This part's working for me. This part's not. Like I'm really busy on the weekend. Sorry, I'm really busy during the week with my work. Weekends are when I do all my activity. I've got to clean the house, walk the dog, get to netball. I stand all day, do this, do that, go shopping. And so sometimes that took a little bit of time to educate, particularly around the mid-portion Achilles tendinopathy, where load is a critical piece of the rehab. So it just took some, see how you're noticing, your pain goes away, and then you do all this activity on the weekend, and then, Monday morning you're really sore. That's because, and sort of going through and applying those personal examples of what they're telling me, in integrating that into the education, so that some of those people that really required a lot of coaching was about the relationship. It was about them feeling safe to share the truth, safe to be challenged. And a common question I would ask these people was, well, okay, so what would it take then for you to, what would need to change for you to be able to apply what I'm asking you to do? Because often they wanted to do it, but I just don't have time, and I'm busy, and so some conversations sounded like, so what would it take for you to be able to apply this rehab then? Oh, well, I would need, actually, if my partner took the kids to school, that little window of time, that 20 minutes would actually enable me to do the exercise program. Okay, so is that an option? Do you have a partner, and do you have a partner who'd be willing to do that? Oh, yes, I do. Okay, so what would need to change for your partner to take the kids to school? I would need to ask. In fact, actually, every Sunday night we have a family meeting and we have a conversation about how the week's going to look, and I could ask, okay, well, why don't you do that? So, I mean, but that's not a day one thing. That comes out of the relationship, and that comes out of the follow-up and the conversation, and also patient not feeling accused or threatened of, or you need to do this. It was actually, well, okay, well, what are the barriers? Let's work through that. So that was the coaching group. And then the last group were the group that really needed flexibility. And that profile was more challenging for me. And probably because of the context of a clinical trial, where really we've got one protocol that we're delivering, and it's important that we deliver that protocol, and the way that I'd chosen to measure or to view adherence. But for those patients, I think future research would be really interesting, and I think some members of our group are looking at embedding this into their projects. I think, so these patients, they got it. It's not like they didn't understand, but either they sort of weighed up that effort versus reward. And so some of the comments were like, I'm not training for the Olympics. I'm fine with a little bit of pain. I'd rather have a little bit of pain than do what you're asking me to do. But I'll apply the general principles. I'll modify the load. But if actually, if I'm going away on a trip with my wife and she wants to go for a long walk, I'm going for a long walk. But I'll know why, and I'll manage it, and I'll do some exercises in the lead up to sort of help build the load capacity. So there was those patients that they understood, but they needed the flexibility to apply the principles. So they needed to really understand the principles. They also didn't need me saying, no, that's not right, or you can't do it that way. They just needed some, general guidance to be able to, rather than fit the behavior change piece was not fitting the exercise prescription into their life. It was actually, how can we modify the principles of the exercise prescription and the activity loading advice so that it fits into the patient's life? Sometimes they would get home from work, do the exercises on the front porch before they got inside the house, because they knew once I get in that house, turn the kettle on, make a cup of tea, I'm not doing exercise. So they kept their little weights at the front door, and they'd use the step. And so that for them, just integrating some things that worked for them. Again, heavily reliant on building that relationship, that therapeutic relationship where they're comfortable to have that conversation, and you can work with them to be able to identify what might work for them, or even say, okay, I understand that's not working, but that if you're applying the principles that way, these are the likely outcomes, and allowing them to weigh up those outcomes. So that they're the primary things. So I guess that's from an application perspective. From the sort of findings perspective, I'm going to refer.
Well, while you're looking that up, Bec, there's, just to sum up, there's that final category, those who are valued flexibility. They seem the opposite from the first category, that they wanted a plan, they wanted specific detail. And I think you summed it up best when you said everyone's different, not everyone's the same. There's real value in the start of your career, especially as a student and then a new grad, to just consider that there's these different profiles of people. They're probably on a continuum. There's many combinations of these profiles, but you can't apply the same strategies with every person. In that second group who valued coaching or required coaching, and the therapeutic relationship was important to them, that was a classic motivational interviewing question that you asked. What would need to change for you to be able to do that? And that's really putting it back, or enabling them to come up with a solution, isn't it? So these are almost the toolkit, or the bag of tools that you carry around with you, that just takes time to develop. as a practitioner. But I wish I'd known some of this when I was struggling as a new grad, and you'd have somebody responding really well to your approach and your methods, and maybe they were in the flexible group, and you have someone else who they didn't lack motivation. They had all the knowledge, but they needed specific. They wanted to know, what's the final decision?
Yeah.
What am I doing? What's the final? I know all this stuff. I've heard this from this person, that person. I've listened to the podcasts. I've got all the information. Give me the plan. And the flexible person knows the plan, but they want to apply that in a way that works for them. I wish I'd known some of this stuff when I was younger and practicing full time.
Yeah, absolutely. I think that is a really important skill, and it's reading the room. It's reading this interaction. Okay, I'm getting a little bit of pushback here. Why is that? So rather than going harder, consider it like that self-reflection of like, maybe this is not the right approach. Maybe I could modify my approach rather than, no, there's one way to do it, and I'm the expert because I've just graduated and I know what best practice is, and you need to do best practice. Sorry to interrupt, how much does the psychological or flexibility or the personality of the practitioner come in there, the willingness for them to do things differently depending on their audience and read the room? Yeah, I think we're all different, right? We all have different personalities. So I would hesitate to say that it's about our personality, but I think as the practitioner, it's our job to modify ourselves to meet the patient where they're at. So rather than expecting the patient to be receptive to our one way of delivering things because that's our personality, it's just how we do things, I think that adaptability for you to know, well, I like receiving things this way, but not everybody's like me. So we just that openness to what am I reading here? What sort of body language am I getting? And what, are they checking their watch and sort of checking out, being a bit disinterested? Maybe they don't need all the detail. Maybe they don't need all of this education that I want to give them because I'm passionate about it and I would need it. But just actually this person just needs to cut to the chase. What do I need to do? So reading the room a bit as I think that adaptability, that we adapt ourselves rather than expect the patient to adapt, and also a bit of humility that the patient is the expert of their own body and they're expert of their own life, and they're with you for a short period of time, and then they're going to go and live their life. And so we adapt ourselves to being able to meet their needs. I used to think physio was like a consultant. I used to compare it to the business world a bit, like I've got this expertise, I've got my training, I know what I'm doing, I know what the best practice guidelines are, I know what the evidence says, and they're coming to me for me to tell them what the evidence says. And then, good luck with that. As one of my patients, one of the participants actually said that was her experience of physio. Here's your exercises, good luck with that. And I think, again, with the experience that I have, I really, one of the phrases that I want to eradicate from physiotherapy world is, come back if you need. I'm here if you need. See how you go with that. See how you go with that. Come back if you need. No. Manage the condition. Have in your communication. Patient's the expert of their body. They're the expert of their condition. They're of their experience of the condition and their life. And your job is to meet them where they're at and to explain the injury and explain the management and collaborate together to work out how what they want from you and what their outcomes are that they're looking for, and help them manage in that way. So I don't see it as a consultancy anymore. I see it as very much a collaboration with the patient as the expert of themselves, and I bring some knowledge and some expertise and the clinical practice guidelines and the evidence that we have, and then my job is to help them apply it in a way that works for them.
And can you help everybody? Are there some people who are better off seeing somebody else for reasons that you may not have time or the ability to uncover? Is that
That's a really good question. That's a really good question. And I think if you are, if with humility, and if you have the maturity to be able to adapt yourself and the self-awareness, then I think you can help everybody. Does that mean everybody's going to do exactly what you said and that will have perfect adherence? No, that's a part of it. Accepting that actually this patient doesn't want to be an Olympian. They're happy to accept a little bit of pain, but they just need to be able to apply the principles, and maybe that's okay. So I think, yes, you can help everyone. With the clause that I would put in there is system constraints sometimes are in our control and sometimes are not. And as a private practice clinician, I guess I had more ability to manage those system constraints, and it might mean that I need a 30-minute consult here, or sometimes I might need a 45 or I think some experts have like an hour as an initial, and then they have follow-ups that are much briefer. So if you're in a public system, or if you are in a private practice where you don't have the flexibility and you're trying to see people in maybe 20 minutes, you might not always have that ability to connect with the patient that needs the coaching, or you might just need to sort of splice it up a little bit, and so you just give it in smaller increments. But again, that's about your adaptability. So I think it can be done. It's just more challenging if you've got more system constraints.
And what we're doing here is just creating awareness that these factors exist, and that people are different, and there's system constraints. So again, conversation I wish I'd listened to when I was a new grad, but that's why we're doing the conversation. Primarily for our students and new grads and anyone else who finds it interesting. So you're going to talk about your findings. Did you manage to look up the doc?
Yes. I did. So the four main themes that I arrived at, that after applying a framework analysis, that each of these four themes had three mechanisms that influenced adherence. And so the first was tendinopathy paradigm, and that was about one of the mechanisms for optimizing adherence was meaning making of load and pain. So keeping in mind our participants all had mid-portion Achilles tendinopathy. So they really needed an understanding of load and what load is, because that's not obvious to most people, and an understanding of pain. So bringing in some of the pain science stuff. Also, another mechanism was comprehension of new knowledge. So for some people, they were a bit stuck in, they thought they understood management, and we've progressed since then. Our understanding has progressed, but that ability to shift and accept, comprehend, and take on new knowledge, sort of leave that sort of past behind and comprehend something new, making that shift for some people is really challenging. But it was important that in the presence of the ability to make that shift, people the adherence was optimized. And the third mechanism under tendinopathy paradigm was operationalizing knowledge. So it's fine to understand it, but then the application to life. So there was comments from participants who were saying that the ability that we had together, or my ability to personalize their knowledge, it wasn't a cookie cutter approach. It was understanding, and she was kind of blown away by the fact, I don't know why I remember, the dog's name and the daughter's name, and then what her schedule was on the weekend. I would struggle to remember most people's first name, but I knew her routine, and being able to apply the rehab to her routine was really helpful for her. So that's operationalizing, not just this is what it is and this is how you do it, but working together to operationalize that knowledge. So that was the first one. The second theme was self-management skills. So in the presence of having this internal self-management capability, external life rhythm management, and also being able to manage physical capability, in the presence of those mechanisms, we optimized adherence. So some people came with those fairly naturally. A lot of people in the high adherence group, they liked routine. they were structured people. They had alarms. They already had exercise routines that they're like, right, got that routine already. Instead of doing my run, which I can't do because of my Achilles tendinopathy, I'll do it there, and life doesn't happen until I've got it done. Or they just were quite structured people. But others really, that they needed quite a bit of coaching to manage the internal and also external sort of rhythm of life. And there were some real challenges in managing physical capability as well. If you needing to add load, but you've got also a shoulder injury or knee injury or other things going on. Needed some flexibility from the therapist to be able to work together to collaborate on their rehab program. The third one of the four different themes was therapeutic relationship, which we've talked a bit about already. And that was so in the presence of having pre-scheduled regular check-ins that came out across all of the different themes, was around across all the different profiles as really important for adherence. It allowed accountability, it allowed the connection, it facilitated connection, it provided that reinforcement and reassurance that some people knew they needed, some people didn't really know that they needed, but having the pre-scheduled, it was not adding to the cognitive load, and it didn't get squeezed out by other things and demands of other family members or caring responsibilities, but that pre-scheduled, before you leave, let's schedule it in, our next visit as it is at this time. And that really feeds into my dislike of see how you go with that. Let me know if you need. People don't call back. People are busy. They leave your office, their phone's ringing, they've got 3 missed calls, they've got to pick up the kids, someone's at basketball, got to get dinner. Like they don't leave your office and go, actually, I think I'll, they straight back into life. So before they leave, and I think that's part of that communicating as well. This injury takes this long to get better. And we find that managing it this way works really well. So that collaboration, we saw people for 52 weeks. These injuries take about 52 weeks to get better, but I didn't see them every week. I saw them 6 times in that 52 weeks. So just being able to communicate to patients, really that pre-scheduling the regular check-ins was really helpful. Personal professional connection and coaching support, which we've talked about. The last one was focus on the outcome. So, people across all the different profiles expressed an motivation to maintain functional ability with progressing age. So that was sort of probably the key one. And also framing success. Some people were quite focused on, but my Achilles is still thickened. And I was saying we know that's not a good measure of whether or not you're getting better. Are you able to play some one-on-one basketball with your son? Well, that's what I'm using as a measure, not whether your Achilles is thickened and still tended to palpate. So sort of helping them frame what we use to measure their improvement.
It's absolutely a suggestion that's come up on previous episodes. Just thinking about the person and what's important to them.
Yeah.
And so your PhD is under review. You've got papers under review as well. And your final paper was a co-design protocol, wasn't it? So you were trying to develop resources to target physio behavior to improve rehab delivery, right?
Target the physio behavior. That's the one.
So what sort of resources will you develop for physios? Because so you've gone deep here, podcast style. We've gone into all this information, and it's always good to have a summary as well. What resources have you developed so far, or what will you develop for that protocol? What's next?
Well, that's kind of the point of co-design. It would be remiss of me to preempt that. I think to answer the question properly would be remiss. But of course, I've got some ideas. So sure. I think there is an Achilles tendinopathy toolbox that already exists. You can Google that. Alison, I don't know how to pronounce her surname, Izat, I think, has developed that already. So I think that she may have used Trek. So we can add that as a link. So there is a physio toolbox already, but there's not a lot of behavior change elements and looking at how we deliver it's got a lot of evidence in there for what to deliver, but not a lot of guidance on how we deliver. So for me, I think the resource that's targeting physio behavior is all about the how. And so throughout my thesis, I used the COMBI model, it's part of the behavior change intervention ontology, which is something I would suggest if people are interested in behavior change that they could look up.
Just explain the acronym of COMBI. So
COMBI is capability, opportunity, and motivation. And it's based on behavior change theory. And so capability is broken into physical and psychological capability. It's a lot about the knowledge. So having knowledge of what to do. Opportunity is social and physical. So a lot of that's related to time and a lot of physio resources. Physios are aware of that. People don't have heaps of time. I think gone are the days where we give people 3 pages of, exercises that you narrow it down. What's going to help the most? So time is a big part of that opportunity, and social as well. Social opportunity, access to physio, access to care, access to funds, finances, financial accessibility, geographical accessibility, and then motivation. So that's automatic and also reflective. So automatic is about what are you in the habit of doing, and that actually came out in my scoping review that we don't include habit. Teaching patients how to build a habit is not typically reported as being included in rehab protocols. And so I think taking some time, it's a good investment of time to teach our patients how to build habits of exercise, but don't do that if they already have one. So that's about knowing your patient. So some patients already have an exercise routine. They know how to build a habit. Others don't, and that's why they ebb and flow, and they have good intentions, but they haven't ever been able to actually implement those in a sustainable way. Those are people who they're motivated, no problem with that, but teach them to build the habit. So so that motivation, and then the reflective motivations about your values, and that's quite personal, but often your patients, certainly the ones that do return to see you, they're motivated. They want to get better. They want to get back to their life. So I think that's another thing for physios. Don't assume people are not motivated. They are motivated. And so with the right delivery, you can connect that so that, they do adhere to their rehab.
There's another episode, building habits. It's a topic of some very well-known best-selling books, but also, applying that or thinking about that in our practice. I like that the last point you finished on there. Don't assume that people aren't motivated. They may have they may be in a different category as you categorize them in terms of their, the high partial or low adherence groups. So that those who needed detail or those who needed coaching or flexibility. They're really interesting ways of framing and looking at the different types of people that we'll work with, rather than the approach of you being a consultant and there to deliver expertise.
And then when they don't do it, and then when they don't do it and we say, patients never do what we tell them to, again, another phrase that I'd like to eliminate from physiotherapy vernacular, maybe it's about how we deliver it, not so much about your patient not being motivated. So not assuming that they don't want to do it or can't do it or won't do it, but actually we'll connect with them and find out what they need from you to be able to adhere to the rehab program that you're delivering.
And this type of research will make its way back into physiotherapy curriculum. We're both involved in that. And the next generation of physios coming through will have so many skills that we didn't. We go out there and we're wondering why things aren't working. And there's frameworks for understanding this. So really interesting. I feel like we could keep going on, but you've given us a really nice summary of your work so far. Give us a couple of takeaways that we could go, or even some further thoughts, the resources, things to look up. Where can we end this?
Yeah, I think be open, always keep learning. find a community of mentors and people interested in the areas of rehab delivery. And there are other resources around communication for health professionals. There are short courses that you can do. Thinking Physio is one that there's blogs and podcasts that you can listen to. I think it's just that awareness that the patient is the expert of their body, and we're connecting with them to help them. So I guess that's back to the humility piece again. The patient's not the problem. If your patients are not adhering to your treatment, then perhaps you need to review your delivery rather than view the patient as the problem. That's probably the key takeaway. Yeah. So there are some resources on that. Sorry.
No, that's great. And I'll put all those resources in the show notes so people can, and your papers as well. We'll put all the links in there. Just to pause and be able to think about the problem of adherence in the person that you're working with, rather than just being in the weeds and trying to deliver exercises and lifestyle modifications and then wondering why nothing's changed. It's a really important part of our reflective practice. So I'm really happy with where that conversation went. You've done a PhD. It's really hard for some people who've just finished their PhD to go and apply that and get out of the details and the methods of what they've just done. But you've spent 30 years leading up to that point, so it's easy for you to return to applying it to clinical practice. But fantastic, Bec.
Thank you. I'm grateful that there's a lot of qualitative research now happening in physiotherapy, because I think we know a lot. We know a lot of stuff about a lot of stuff. We know what we know. We've got good clinical practice guidelines. There's a lot of evidence out there, and that's great. But in order to be able to apply that to your patient, it requires some of this stuff. And so, I think it's a really nice combination. It's a great place to be, a great time in history to be graduating in a physiotherapy career, because we've got a lot of knowledge about what works. So rather than considering your patient to have failed conservative therapy, let's consider how we're delivering the clinical practice guidelines. That combination of the qualitative research with the quantitative research. Before we consider it to have worked or not worked, we need to know about whether it was actually applied.
There you go. You've done a really good job there of summarising a really complex topic and many years of work and clinical practice leading up to that. So some really valuable insights. We should mention your PhD buddy, your colleague, Matthew Kenny. So Matt's currently finishing a really similar or aligned PhD topic, looking at gaps in adherence reporting across the musculoskeletal published literature. So watch out for Matt Kenny's published work. I'll put all of Bec's published studies in the show notes, and you'll see more being published in the future, and a list of all the other resources in there as well. Can you be followed online? Are you LinkedIn?
LinkedIn is probably the best place to find me.
I'll put your handle in there as well.
Yeah, that'd be probably easier, because my name is a very common name, and there's probably hundreds that would come up if you just put Rebecca Phillips into LinkedIn. I'm also on Instagram, less than LinkedIn, and it's not as scientific, but obviously, moving _free_physio is my LinkedIn, is my Instagram as well.
I'll put them in the notes. Those avenues for connecting with people and sharing research and sharing practice insights are really valuable. So you can connect with Bec on LinkedIn and Instagram if you like. But thanks very much, Bec. Thanks again for the conversation. I feel like we have more to talk about, so we'll have to do it again in the future.
Thanks very much, Luke. My pleasure.
All right, so everyone, if you have enjoyed the episode, consider sharing it with a friend or a colleague or a fellow student. If you want to continue the conversation with any of the guests on the podcast or with myself, you know how to connect with us. You can find all my handles in previous episodes or in the show notes, and let us know what you think about the conversation. Continue the conversation online. I have forgotten my usual sign off. I've only said it 84 times, so I'm going to do it by memory. Let's see how we go, Bec. So until next time, this is Bec and Luke wishing you all the best with your studying, professional development, and lifelong learning.